Well, the problem first appears before patients know that they are infected by NTM. There is a huge underdiagnosis of NTM because physicians do not have this complication in mind. And the major reason for this is that NTM has been thought to be a disease of immunocompromised patients for a long time, but now we know it's also a disease in immunocompetent patients, in patients with chronic lung disease, for example, COPD patients and bronchiectasis patients. So what we have to do in the future, we have to stimulate to diagnose NTM. We have much better tests today to find the bug and to diagnose the disease. And we have to do this. The second problem is related to treatment. It's a complicated treatment, it's a long-term treatment, it's a treatment with a lot of side effects, and what is a real need is the development of new treatment options which are better from a benefit-harm ratio view. It's a progressive disease. We do not have a very efficient treatment. There's a lot of compliance problems together with the treatment. And so because of this disease progression, life quality is very bad and patients are very often hospital admitted. So to conclude, it's a really expensive disease due to the very often hospitalizations, and it's a disease which affects the life of a patient very thoroughly. We look whether the diagnosis of an NTM pathogen has a pathological feature in the chest X-ray or the CT scan, and whether there are symptoms which are in line with NTM diagnosis. If a patient is symptomatic, we start normally a 3-drug treatment with 3 different substances, a macrolide, rifampicin or rifabutin, and ethambutol to get an efficient improvement of the patient's symptoms. All these drugs have side effects, and if you take 3, you have more than an addition of side effects, so it's a multiplication of side effects, and a lot of patients do not want to take the drugs anymore, mainly because the gastrointestinal side effects. And so the patient's compliance with this treatment is very bad. This is much more a problem in patients who take drugs for other reasons, because the interactive potential of the antibiotics used in NTM treatment with other drugs which are metabolized on a hepatic route is very, very huge, increasing the number of side effects and dropping down the treatment adherence. Inhaled antibiotics are thought to be, in a way, a solution of this difficult to treat patients, because if you use an aerosolized route to deliver the drug, it's only focused on the lung and the number of side effects is reduced. With inhaled amikacin and a manuscript, a publication of a phase 3 study finalized last year will come up in the Blue Journal with an inhaled antibiotic, and this is mainly inhaled amikacin. We were able to show a better compliance and a better conversion rate, so we were able to reduce the burden of NTM in the patients. I think inhaled route is the future of NTM treatment.